any acute liver failure is curable. So, is it so? So decreased over the years, and also the survival among those with severe encephalopathy. So earlier the survival was only around 20%, but now it is close to 70%. So what is the change that has happened in the last 2 to 3 decades? So that's what our panel is going to discuss. And the two things which has made the difference is the emergency liver transplantation and the advances in critical care. So we have all the panels which representing that. And we will be discussing a case, and in addition, the two things, the liver transplant and the plasma exchange, will be talked in detail by Dr. Joy Varghese and Dr. Ilan Homan for about 8 to 10 minutes. So let's take up a typical case which most of us would be familiar with. We have an 18-year-old boy who has just failed his 12th standard exam, and then he has taken 2 tubes of this Crrp paste. So this looks something like this. And he has taken it at around 1 p.m. He has not told anybody, but around 3 or 4 o'clock, he develops vomiting, and then he gets scared, and then he tells his family. So they rush to a nearby, they are from a small village near Tirchi, and they rush to a nearby PHC. So Dr. Bhaskar, if you are there in a PHC, he comes to you. So how would you deal with him? And I also want to know if you are working, now I know you are in Chennai with a tertiary center. So will your approach be different if you see this boy in a PHC or in Chennai?
In the first time I was in a primary health center. So if the patient comes to me with the 4 hours from the initiative, it took around 1 o'clock. He came to the emergency around 4 o'clock. So basically he lost the window to do the gastric lavage as well as the activated charcoal. Because all the guidelines clearly state that if the patient comes to the emergency within an hour, they will get a better gastric lavage. If you have activated charcoal, they said the more superior than doing a gastric lavage, so try to go with the activated charcoal from 1 gram per kg. 1 gram per kg, they can maximum go up to 50 grams. If in my premises, if I have a charcoal, I will try with that. If it in Chennai, I will do the same thing because the priorities is not going to change if it in acute poisoning. And meanwhile, with symptomatic treatment, I will ensure him to keep in hospital. That's the way I go ahead.
Yeah. So you will admit him, and then whether you have to give usually most of the poisons we are thinking whether we have to give gastric lavage and activated charcoal. So within 1 hour, yes, if they come and if they are able to do that, yes, it is best. But most of the time, people never reach us in that time. And then now in the last 2 months, there's no real guidelines about management of yellow phosphorus poisoning. Liver Transplant Society has recently brought one guidance that is more geared towards transplant. And then Tamil Nadu IST has done a phenomenal work. They have conducted a study in 2019, and based on that study, guidelines have been published in January. And that says that up to 4 hours, we can give, maybe there may be some difference of opinion, up to 4 hours, we can give gastric lavage if the patient's sensorium, everything is intact, and activated charcoal also. And all the patients should be admitted. So Dr. Joy Varghese, so you think even when the patient is initially stable, we'll go ahead and admit, so depending on the stages?
Concerning this particular patient, the tubes, it's a huge quantity to cause the acute liver failure because normally the lethal dose is the 1 milligram per kg body weight. 18 years old boy, even if you consider 50 kg body weight, so 2 tubes is huge because the 1 tube normally comes around even 10 grams. Some of the tubes are available, the 10 grams, some of them 5 grams tubes. So definitely even 50 milligram, 50 kg body weight, 50 milligram alone will definitely cause the IPA. So I will admit the patient, even though patient is stable.
So they are defectively stable in the first 48 hours, and then only the liver injury starts with yellow phosphorus. So all patients need admission irrespective of, even if they are stable in the initial stages. So day 2 also the patient is there in our hospital. Where would we keep him, Dr. Bhaskar? Will you keep him in a ward, or where would we keep him in the first 2 days?
If you came to know the yellow phosphorus poisoning, initial 3 days it will be okay. We will keep in wards. Just he needs a laboratory monitoring, and the hemodynamics to be checked. If in the 3rd day the LFTs are being started getting deranged, that time we may think to shifting to the ICU or HPU. Basically, it means cost cutting.
Yeah. Yeah, Dr. Bhavna, you can add.
I still think that we should monitor these patients in not in an ICU, but especially in a supervised setting, because these patients go into encephalopathy very quick. We will never know, and most of the time we can't trust the history. We can't trust that they have exactly taken at 1 p.m. So what we can do is at least a supervised setting like a high dependency unit or something like that, and especially to monitor the GCs, because it will be very subtle. These patients slipping into encephalopathy will be very subtle most of the time.
Yeah,
Dr. Hema, what would you recommend on day one evaluation when the patient comes to us? Patient is stable. What are the baseline investigations you'd ask for?
Okay, so Dr. Joy, you want to take that baseline investigation on day 1 and day 2?
Regarding the yellow phosphorus poisoning, the treatment, so slowly we are evolving actually, because based on our experience over the last many 5-6 years, initial period we immediately started the NAC infusion and all the things. So nowadays the quantity of the poison, that is very important. So we can ask the family members, I think if they have taken very small, just to from the family. So that time, just liver function test and observation, we can, that's more than enough. If they have taken the half cube of the poison or more than that, so that time we have to start the NS system.
So generally we do routine biochemical.
Can I think you are only correct, but as she rightly said, you can never believe the relatives, how much they have taken, when he has taken, all those things. I think that should be a blanket statement that these patients should be admitted and observed. More than that, just because this is a gastroenterology department, we need not talk only about the liver, because the yellow phosphorus poisoning doesn't affect only the liver. The first 2 days, the mortality is high only because of the cardiac involvement. So you need to admit the patient and observe, and you need to bring in all your other colleagues, general medicine, cardiologists. And as she rightly said, they slip into coma in no time, because it can affect the brain also. Sometimes it can affect one of your publications, pancreas. So it can affect the pancreas. So it is not only the liver.
Generally, we will do the CBC, renal function, electrolytes. Yeah.
Something else interesting that reminds me is we had a patient with so-called yellow phosphorus poisoning, especially when it comes to poisoning. Most of the time we just stick to it, but I think these patients we cannot trust. We should still consider sending a toxicology panel, because we don't know, there might be some other drugs that we have taken, like some anti-epileptics. The patient is already a depression patient. So worth considering a toxicology panel maybe.
So we don't have toxicology panel, I think, we have any
I suggest
paracetamol levels we have.
yes, ma'am. I was thinking maybe some other drugs that can also push the patient to.
Yeah, definitely. So routine daily monitoring of the blood parameters as well as clinical monitoring is needed, and as expected. So this patient has come with a history of yellow phosphorus poisoning. Sometimes we see them on this day 3 only with this kind of labs. They come with some nausea, they're not feeling well, and then we see these kind of labs. Okay, so now this is getting a little bit scary. So now so this is just so what do you say, Dr. Bhaskar? Is the indication to shift him to ICU now, or you still want to keep him in a ward or a supervised care?
Yeah, because as you said, initially the patient took 2 full tubes. The LFT started deranging, INR is going up. This patient needs to be shifted to the ICU, and we need to started working for the acute liver failure evaluation. Meanwhile, we need to, like we said, we need to involve other specialists in the loop, bring an nephrologist, cardiologist, and as well as the gastro team. Okay. And mainly liver transplant team also, because he started decompensating, because the 3rd day the symptoms obviously goes after 72 hours of taking the ratal poisoning. The LFTs have started deranging it. He's a candidate for liver transplant if the numbers are going up.
So this patient has come with a history of yellow phosphorus poisoning. But if we see someone with just these lab values, so what is this called? Is it acute liver injury or acute liver failure? I want Dr. Joy to differentiate that. Now, patient is conscious, alert. So without the history of yellow phosphorus, if we see somebody with this kind of labs, so
this is we can define as acute liver injury. Whenever the patient is getting the altered sensorial, any grade 1 to grade 4, then we can change the terminology to the acute liver failure. So we are seeing so many patients will get the acute liver injury, but they won't go into the acute liver failure. So it is not only for this rectal poison, any irrespective of the etiology, any liver injury, if the patient's acute liver injury goes to the altered sensorium at any form or any grade, then it calls as acute liver failure.
So as John said, the presence of encephalopathy is required to define a patient as acute liver failure. But in yellow phosphorus, this transition from acute liver injury to failure can occur within few hours or 12 hours. So that is why we need to be very cautious. So if the yellow phosphorus etiology is not there, what other etiology will work up in these patients?
So whenever we are seeing the acute liver failure, we have to go for all the routine etiology, viral serology, that is under the autoimmune profile, under the metabolic workup. So in the detailed, suppose if you are seeing an acute liver injury of any patient, just we have to go for the screening for the things. We have to put all the details. All the viral serology and the toxins comes into this retinol and the other Wilson's. The pregnancy related, so this is very rare actually. Nowadays, we are not seeing that much of the acute fatty liver of pregnancy. So that kind of things, I mean, very rare. And the vascular in the pediatric also we have seen in the middle age, the acute Budd-Chiari syndrome. That time also, even though it's acute liver injury, we can try non-surgical, that means interventional wise, we can revert back. Suppose if the patient develops the acute liver failure, then if it fulfills, so whatever the etiology, the patient has to fulfill the King's College criteria to take the patient for liver transplant. If they are not fulfilled for King's College criteria, we can inform the family members, we can tell that at one point the patient might go for liver transplant, and then we can prepare, we have to prepare the donor rights, financial, everything. So at the same time, if we are based on the etiology, we can start the treatment also. Treatment slightly vary. If you take the acute Wilson, the plasma exchange, this is not only for the recent days, for many years, there are the children, either the acute Wilson or acute presentation of the underlying chronic, the Wilson, the children, the plasma exchange will help. And regarding the antiviral, there is no role so far for the antiviral, for the B virus, the things that we can start based on the Dr. Sarin's criteria. So we can start the therapy, but it's not to revert back that acute liver failure, acute liver injury. It is just to bring down the viral load. That's enough. That also very short period. It will not be that much helpful. So based on the etiology, the treatment we can initiate. We will try to progression of the acute liver injury into the liver failure. But still, if the patient goes to acute liver failure, we have to look into the King's College criteria, whether they fulfilled or not. All acute liver failure doesn't need to fulfill King's College criteria. They might have the acute liver failure, but still the King's College. So that time we have to our ICU intensive care unit wise, there is a chances. That's why the recent papers are coming up with a very good ICU critical care wise. We can prevent the ongoing King's College. Even sometimes even King's College fulfilled, there are the chances the patients comes out without transplant also.
Yeah, thank you. So we need to, so when we do not know the etiology, we need to do a full workup and do a specific management wherever indicated, like as we said about for Wilson or antivirals. So there are some tropical infections which can mimic acute liver failures. Sometimes we see dengue patients coming with very high transaminases and prolonged INR. So now this patient who's been having nausea, INR is prolonged, and now lactate is 3, ultrasound we have done, they say some suggestive hepatitis. So now we are definitely going to give this patient to Dr. Nandakumar and Dr. Bhavna. So when you are going to take care of this patient, what time exactly to start the discussion about liver transplant? Do you want to start the discussion at this point itself? We will. So there are two aspects. We will discuss about how they are going to manage the ICU care of this patient, which is going to be one of the most important aspects which decides the final outcome of the patient. Without the ICU care, the patient is not going to come out even if we do the transplant. So, what are the problems you expect at this stage, Dr. Nandakumar? He is liver transplant anesthetist in Apollo Hospital.
So we have to treat this patient in the ICU. Since he is conscious and alert, I think there is no role of sedation at this point. And sedation is actually contraindicated at this point because it will hamper with our ongoing assessment of progressing encephalopathy. So, and again, the lactate is 3. So we need to evaluate the hemodynamics and about the resuscitation also to see whether the lactate can be decreased with the fluid resuscitation. And again, the second most important point is assessment of the grade of encephalopathy. So since if the patient is cooperative, conscious and alert without any drowsiness, we even use psychometric tests like number connection test to evaluate for subtle encephalopathy and the progression of encephalopathy also. And coagulation, we don't correct coagulopathy unless there is clinical bleeding or there is evidence of severe coagulopathy in point of care tests like thromboelastography. Second, the renal function. Third is the renal function because the yellow phosphorus poisoning can have severe renal dysfunction due to tubular necrosis, and we will evaluate the renal function and in case if needed, early initiation of CRRP also. Fourth is liver supportive measures. To add to the initial discussion, there is literature which shows that early initiation of N-acetylcysteine IV at the point of presentation of the patient in the ER or to the ICU will actually improve the outcome, at least in patients with less severe liver failure.
So when will you initiate, like after the liver tests have gone up, when once the transplantations have gone up, or you would know that we know that he has come with a very toxic dose of injection, would you like to start it earlier, or what does the guideline?
Like if the patient is presenting to the ER and there is considerable history which says that the patient has taken adequate quantity of yellow phosphorus, it is better to initiate N-acetylcysteine at that point because N-acetylcysteine initiating after 12 to 24 hours has shown no benefit compared to early initiation.
So as you have said very clearly, so N-acetylcysteine is one drug which is very useful because it depletes the glutathione stores in the liver. So initial studies were with paracetamol poisoning, and then they have also done with non-paracetamol poisoning, and it is better. The benefit is more with early grades of encephalopathy. So not much use once the patient becomes grade 3 or grade 4 encephalopathy. So the N-acetylcysteine is one drug which you can start early in the course of the drug intake itself. So this is the Tamil Nadu IST guidelines about the N-acetylcysteine. So this is almost similar to the ones which is used for paracetamol. So how long are we giving nowadays? Are we giving for only 24 hours? Are we giving for 72 hours? So Dr. Joy, you can take us, and others can also add.
So not for 24 hours. We will continue the therapy until the day of surgery. Even after liver transplant, also mostly the N-acetylcysteine will continue. Not particular to this case. Normally, in all post-liver transplantation, they will receive that N-acetylcysteine in immediate post-op period. The recipient, even donor also, the living donor will get it. So N-acetylcysteine is not only for the, as I correctly mentioned, the ALF or parasitic. So now the indications on the wide range we are using. Particularly this we will see that I used to mention the cardiac ICU. They'll make a call over to us whenever the patient is hypotension. They will get the ischemic hepatitis. The liver enzymes will be very high. So that time also the N-acetylcysteine is the protocol choice. And the post-phase, the transarterial chemoembolization or TARE therapy, there is a transplant. That time is already my colleague here, Dr. Chandan has already published the paper. So the usage of the N-acetylcysteine to prevent the post-phase induced the liver injury. So N-acetylcysteine is one of the drugs.
So IC people would like to add. So even though so most people would start for much longer periods. You can take up the balance.
So
guidelines which mention that it has to be minimum given of 72 hours, but there are places and there is literature evidence for as long as even five days. But eventually, if what I'm trying to say is by the end of day 3, day 4, if the patient goes to day 3, day 4, it's become futile. There's no point. But if the patient recovers, it's good. That meets our objective of and which NAC is already shown. So 3 to 5 days should be is a good time.
You want to add anything, Dr.
Dr. Hema, I think the sedation bit also, no, now the Tamil Nadu guidelines say that to avoid all the sedatives because we all go through the liver. So ALF, better to avoid sedation. Yeah.
The early stages, so I think we'll be discussing that also. I think we have one slide on that also. The NSCT system, most people will give for at least 72 hours, maybe for 5 days. And probably if the patient goes to the transplant and post-op also, it's a good drug. And so the resuscitation part, so do you have any particular preference, any particular fluid, or is it, and how do you assess how much fluid to give in the initial, like when you practice in the first day, like when you see the patient on day 3, and then how many fluids you want to give, how much fluids you want to give, how do you want to assess it?
All acute liver failure patients are just like septic patients. They have a very hyperkinetic system. It's a very vasodilated system. So what happens eventually when there is a vasodilation is the effect is the circulating blood volume reduces. We have to resuscitate these patients very aggressively. The choice of fluid, just like any other general critical care practice, is to use crystalloids. Normal saline is a good enough fluid, but the problem with normal saline is we'll have to probably monitor the chloride very carefully, because if you end up having hyperchloremia, you can again push the patient for API, which these patients are already predisposed to. Now, after the first 24 hours, after the initial resuscitation, the ongoing resuscitation is a little tricky. We now know that a lot of fluid is not good. So there are now parameters, there are now monitors which help us to decide how much more fluids to be given in the next few days, 2 or 3 days, whatever. Coming to the choice of fluid, crystalloids, normal saline. What about the balanced other salt solution? The problem is they have acetate and all, which cannot be metabolized when there is an acute liver failure. So we have to be very cautious regarding the other crystalloids. What about colloids? Albumin is okay. Now there was this, I'm sure all of you know about the SAFE trial. So in SAFE trial, we have clearly shown when you give a lot of albumin, the traumatic brain injury category of patients will find it very harmful. ALF patients are very similar to that. Even though they behave like septic, because of the rising ICP, they can also have this, albumin may be dangerous. So better to stick to crystalloids, normal saline, followed by any of those balanced salt solution, which does not have any components, which is getting metabolized in the liver.
So adequate fluid resuscitation is important. Dr. Bhaskar, Nandakumar,
I'd like to differ a bit. Yes, beautifully put. So we have used balanced blood solutions only in these patients, like either ringer lactate or plasmolate. Normal saline, there is a concern with normal saline. Normal saline can lead to hyperchloremic acidosis, and yellow phosphorus poisoning patients are more prone for hyperchloremia inherently because of the poison itself. So it is better to use plasmolate or ringer lactate, and it is also better to define certain endpoints before the resuscitation is initiated. Say the MAP which we want to achieve, or the lactate level which we want to achieve, and then go about with the resuscitation so that we can stop the resuscitation, because since the cerebral, the autoregulation of cerebral blood flow is completely restricted in the yellow phosphorus poisoning, over-zealous resuscitation can lead to exacerbation of this cerebral edema in these patients. So it is better to define the endpoints, and if the patient is hemodynamically unstable, it is better to use further cardiac output monitors also, along with the invasive arterial BP monitoring, and then start the resuscitation with balanced blood flow.
So as you said, resuscitation is important, crystalloids, and we should have a target. What are we targeting at? That is very important. So towards the evening, our patient becomes more sick, the INR becomes 7, he is slightly drowsy, he has something like grade 2 to 3 encephalopathy. So at this point in ammonia also we have checked. So I want to ask Dr. Bhaskar, so this ammonia, So this ammonia and this encephalopathy, sorry, Dr. Nandakumar, sorry. So this ammonia and this encephalopathy, how is this ALF different from chronic liver disease?
Chronic liver disease patients, there is a low-grade elevation of the basal ammonia production as well as decrease in the ammonia excretion in patients with cirrhosis. So this ammonia, when it starts crossing the blood-brain barrier and it enters the astrocytes in the brain. So due to the chronicity of the disease, there are autoregulatory mechanisms which develop in the brain, which prevents the toxic effects of ammonia, which is entering into the brain. So the cerebral swelling as well as the change in excitatory pathways, which we see in a patient with acute liver failure, is less pronounced in patients with chronic liver disease. That is why even in patients who are presenting with grade 3 hepatic encephalopathy with cirrhosis, they don't develop severe neurological dysfunction as compared to the patients with acute liver failure. The autoregulatory mechanisms in patients who are developing acute liver failure does not develop at all, and this leads to severe cerebral edema in patients with acute liver failure. And again, to add to it, the cerebral edema which is developing in patients with acute liver failure does not actually correlate with the ammonia levels. Even in patients with ammonia levels of 60 to 70, we have seen severe cerebral edema which has presented in the CT imaging also.
So who do you think is more prone for cerebral edema, like younger people or even
patients with ALF?
ALF, yeah.
Extremes of age are more prone for severe fluctuations in the intracranial pressure.
So now our patient is getting more sicker. So Dr. Bhavna, so what are two things you want to now start? So because now we know we are talking about plasma exchange and the liver transplant. So would you call the surgeon at this point to see the patient, or surgeon? Would you call the liver transplant surgeon opinion at this point?
Yes, ma'am. There are various assessments like the progression of encephalopathy and the ammonia levels are definitely high, and the trend in the AST as well as the INR levels. Based on that, we'll definitely call for a liver transplant evaluation, because since this is a rapidly progressive course, early evaluation and preparation for liver transplant is better rather than starting the preparation at a later phase. So we can definitely ask for a transplant opinion. And regarding the transplant reference, I think that the literature shows that INR of 6 as well as a MEL score of more than 35 to 36 has high sensitivity and specificity to predict that the patients will need a transplant rather than spontaneous recovery.
So, Dr. you want to say
actually, it's, I agree with you, sir. But now, because of the scoring system and all the different criteria, it's become even more easier. You can just pull out the scoring criteria. You have for paracetamol, non-paracetamol, you know that these criteria are there. You just can call the liver transplant. Even reference calling, should we move to the other units? If you are in a PHC, you can just go back, see the criteria. It's become very simplified. So essentially, if you see most of these criteria, the bond, everything will have encephalopathy. Most of them will have coagulopathy. So that means, irrespective of paracetamol, non-paracetamol, you have to call the liver transplant surgeon.
So Dr. Velangaman is going to talk. We can now. So obviously there are problems with the scoring system. We know the pitfall. Ultimately, what we want to know is, will this patient recover or not? That's what, will he recover without transplant? That's what we want to know.
Can I make a comment? I think liver poison, the yellow phosphorus poison management is a team effort. It is not a physician, it is not a surgeon. The surgeon has to be involved right from the beginning. At least he will know what is going on and he will make some preparations accordingly. So it's a team effort. The real life scenario, I think, that the surgeon is called the patient is clumsy. So I think when you showed the acute liver injury scenario, that time is the best time to give a reference to the transplant team, because it is not only about evidence and other things. We need to prepare the family for transplant. We need to identify the donors. We need to get the medical legal clearance. So because all those things can be fast tracked and done even as early as 6 to 8 hours in the best scenario, but then sometimes it runs into 2 to 3 days. So it is better to always have the preparation, have the family prepared for transplant, identify the donor, and wait. Not that you identify is not meaning that you have to go for transplant.
Yeah. So he will be talking in detail about the transplant and acute liver failure, the criteria, LDLP, DDLP in the after this one. So we have discussed in detail about all this encephalopathy management. So Dr. Nandagopal, so what are specific measures you use for cerebral edema or encephalopathy? So in CLD, one of we can take, anybody can take. So in PLD, like we'll use rifaximin lactose. Is it of any use in acute liver failure?
No, not really. In acute liver failure, there's no evidence for rifaximin or lactose. Yeah, you've already mentioned about the cerebral edema there.
So this particular slide, no, if you read the guidelines, they'll mention about all these things. But are we using all these? How regularly are we using all these? Which one are we using?
Okay, so mostly it's clinical bedside assessment. We do periodic clinical examination every 15 minutes, go and check the pupil, check the alertness of the patient, mental scoring systems which we have for the GCS. ICP, so the monitoring for intracranial pressure can be either invasive, non-invasive. And honestly, of all that list, we barely use any of those. So the invasive ICP monitoring, I'm sure it has its own difficulties. The reverse jugular venous saturation again warrants that you have to put in a catheter, you have to continuously more and more catheters onto the patient. Transcranial Doppler may not be available at most of the centers. You have to have a radiologist, you have to depend on radiologist. It's not a real time. You have to keep calling in between. If there is a deterioration, again, you can miss your patient. Optic sheath, the diameter, obviously it's better, preferably done in patients who is already in grade 3, grade 4 and is intubated, calm and totally under sedation. Only then you can monitor the optic sheath diameter. So most of these parameters to measure the cerebral edema or monitor cerebral edema is very difficult. In clinical, mostly what we do bedside.
Yeah, so you can add.
So in our practice, we use optic nerve sheath diameter extensively to evaluate the intracranial pressure. And we have also seen that since this patient is 18 years old, late adolescent age, an optic nerve sheath diameter of more than 4.5 millimeters is definitely alarming, which indicates the ICP might be at 20 or greater than 20 centimeters of water. And if the serial optic nerve sheath diameter monitoring shows that there is an increase in the ONSD to more than 5 to 5.2 millimeters, definitely the patient is at risk of significant cerebral edema. And we have to intervene at this point to decrease the intracranial pressure to prevent further complications of the hypertension. And transcranial Doppler is an excellent monitoring, which we use infrequently because of various logistic issues. Since optic nerve sheath diameter is an objective monitoring, but still optic nerve sheath diameter does not give a dynamic assessment of the ICP, but TCT definitely gives a dynamic assessment of ICP. And I think we should use more frequently the TCT along with the ONSD also.
So periodic clinical examination and optic sheath diameter is what most centers would use. I don't think so anybody is using the invasive assessments. So obviously, so at what point would intubate the patient? When would you go ahead
into grade 3, grade 4 encephalopathy? So unlike CLD patients where grade 3 they get drowsy, these patients actually get agitated. So you can intervene by grade 3 in grade 3 encephalopathy. You can intubate these patients. And the idea is in grade 1, grade 2, if they are able to stay calm, basic care what we do bedside is keeping them minimally 30-degree head and elevation, trying to reduce the stimulation, switch off the lights, minimize sedation. But by grade 3, you have to consider intubating these patients to reduce the intracranial pressure.
So it's time for Dr. Joy and Dr. Elankuman also to talk. So apart from this neurology care, the one more thing which we have talked about the neurology care, we will talk a little bit about CRRT. CRRT, that is continuous renal replacement therapy, apart from the routine renal indications, just for ammonia lowering therapy. So, so you can tell us when to start it, how long you would continue it, what about your consideration anticoagulation?
Apart from renal implications like AKI, CRRT in this scenario is definitely helpful for hyperammonemia. We consider CRRT when the ammonia levels cross 100 and if the patient clinically has progressed to grade 3 or grade 4 encephalopathy itself. And even though the patient is hemodynamically stable, we consider CRRT rather than other methods of renal replacement therapy to give a continuous clearance of ammonia until the patient has signs of spontaneous recovery or goes to liver transplant. The second indication is refractory hyperlactatemia. Though the literature does not support CRRT for refractory hyperlactatemia, but in practice we have seen that CRRT can help in decreasing the lactate levels in these patients and preventing and optimizing the acidosis in these patients.
Okay, thank you. So,
To add on, the CRRT also helps in maintaining a more smooth hemodynamic system. So also used in patients who are in extreme shock, thereby reducing the alteration in the ICP also.
So CRRT is used for ammonia removal apart from the routine renal replacement therapy indications. So because we are running short of time, I would call upon Dr. Joy Varghese, who is an expert and he has recently published his PhD thesis on plasma exchange. And after that, Dr. Lankumar will talk about liver transplant. Okay, I don't think so. Both are mutually exclusive, but they will try to still take a fight and talk it out.
So, good afternoon to all. Thanks to for the kind invitation for Apollo Emergency. Actually, I can say this for the given Kati Chandai to me to cause this with Dr. Ilan Gomaran. So thanks for the Dr. Sheshatri. So we keep on touch with me for the last few months. And the plasma exchange in acute liver failure, because earlier, 10 years ago, if you go through the literature, there was no much the plasma exchange in liver disease, even though a few publications was there in the Western world and some of the China and the Japan. It started in Japan almost 30, 40 years ago. Some of the few publication case reports were there. But nowadays, it has been used very well in many liver disease. So acute liver failure, so the discussion going on, it is not a one organ specific disease, it is a syndrome. So acute liver failure, if you go into that, so just that cerebral edema, not only the cerebral edema, it can cause the kidney injury, it can cause the cardiac, the hemodynamic instability. This everything is due to the cytokines, CRRs related. So this is irrespective of etiology of the acute liver failure, whatever the cause, either viral or autoimmune or metabolics, that cause the releasing injury to the hepatocytes, that release of the dams and the following the dams, that releases the number of cytokines, the cytokines causing the other organ failure. So before to develop because we know there's a short duration. So we are at one point, we are telling that patients are not a candidate for liver transplant. How we are judging a patient is candidate, not a candidate for liver transplant once they get the multi-organ dysfunction due to that. So if we intervene at a prompt time, so before to get into these cytokine storm related, the release of all the CRRs related to the organ dysfunction, that time we can save the patient's life. So that is the role of the plasma exchange. If you look into the picture, it is detailed the dams. So not only the correcting the coagulopathy and the clotting factor and fibrogen and the Adams TS. So it's also involves in the rest of the reducing the dams and the PAMs, and that related all the inhibiting the other multi-organ problem. So the therapeutic plasma exchange, we have to initiate in acute liver failure, irrespective of the etiology. It acts as a bridging therapy for liver transplant. Some of the patient, it will use to avoid the emergency liver transplantation. So the question comes, how much volume of plasma exchange to be given. So whatever so if you go through the 2016, the RCT trial from the King's College criteria, Julia Wendell, they telling that large volume plasma exchange. What is the meaning of large volume plasma exchange? Normally plasma, if you take it's a 2/3 of the blood volume is our body is the plasma. If we have a 5 liter of blood, almost 3.5 liter the plasma will be there. So while doing the plasma exchange, by removing one time 3.5 liter, it will not called as the large volume, because to take out all the toxins, it will take 3 times. So almost 3.5 into 3. So that is called the large volume plasma. That time only we can expect almost, if you see the graph, you can see the 95% of the success. So if the large volume plasma exchange literatures all indicates the more close to 3 plasma volume at one point of time in a day, and they have to continue. Then they study, they continued the same treatment for the subsequent days until the patient gets improvement or until the day of transplant. If you are going to do the 1 plasma volume, that means the 3.5, see the so only 63% effect to remove the toxin. So just imagine this all only from the intravascular compartment toxins. So whether the dams or so whatever the injury related, the protection. So if it is continuous, liver injury is a continuous process. That time, whatever we are removing, it will get refilled. So if there is, that's why I mentioned the Wilson disease, the copper, that time it will remove. That's the way it has been helped to temporarily prevent the emergency liver transplant in acute Wilson. So large volume plasma exchange wise, that the paper, if you look into that, the same, the Julia Wendell papers from King's College criteria. If there are the 4 first 2 with the liver transplant, so we no need to concentrate with the liver transplant. We could go into that without the liver transplant. One is the high volume, that's a large volume plasma exchange versus. So it has significantly improved the survival of the patient, but it is not that good. The paper concludes it is not preventing the transplant. That is the one advantage from this RCT trial. It's insisting the high volume plasma exchange acts as a bridge therapy for ALF. At the same time, it's mentioning it is not that much a replacement for the liver transplant surgery. So following that, the paper from Germany. So that Hanwar University is low volume plasma exchange. So nowadays in most of our center in India, they are following low volume. That means 1 plasma volume to 1.5 plasma volume. Some of the centers choose 1.3 and other things. So plasma volume calculation is based on the blood volume. The blood volume calculation is based on the patient height, body weight, hematocrit. So if the pediatric we are going to do, minimal is fine. And the adult, the obese patient, definitely the plasma volume quantity will be more. And we have to think about the replacing fluid. So it is called plasma. It's not a plasma pheresis. It's a plasma exchange. We have to replace adequate proteins. So the protein only we are giving either 5% albumin or FFP. 1 unit of FFP have the 10 gram of protein. And so we have to calculate based on how much plasma volume we are removing. Adequately, we have to replace with the protein. So one end it is removing the dams, stamps, and the cytokines, etc. And the von Willebrand factors related to the high molecular weight protein. Other end, we have to adequately substitute with the proteins. So the low volume plasma exchange, this study from German is also shows it's a very good effective, because initial the thought process was only by doing high volume plasma exchange only the beneficiary will be there. But here it showed it is there. It's also equally effective so in preventing the transplant. And not only that, this study, if you look at the 3, one is the SOFA score, these are ALF study, SOFA and the SOFA cliff and the SOFA related organ failure. So not only the one parent, so day 0, day 3, day 7 is going. So if you see the picture. So the plasma exchange, low volume plasma exchange, if we are continuously doing that time, it is in yellow patients is reducing the score of the SOFA organ failure. That means it is somehow controlling the other organs. Since it's giving the time period to us, go ahead for liver transplant. This is the same paper from our CMC Vellore, Zakaria and Epen's unit. See, if you see, the center is doing for many years for the plasma exchange. So here, this is not for all our acute liver failure. So they are done for the different type of etiology. Cholestatic jaundice, they have done acute liver failure with irrespective. So many, they have done ACLF. So these are the plasma. But the key message here I will mention, in all the studies, they looked into the von Willebrand factor level. So the von Willebrand factor is the high molecular protein. It is getting released from the endothelial dysfunction that is causing the clot formation within the sinusoids and all the capillary levels. So by doing the plasma exchange, it has been significantly reducing the von Willebrand factor, irrespective of whether it is a severe acute, the alpha hepatitis or the acute hepatitis A, or sometimes the DILI, or sometimes rat oil poison, or the patient have the severe alcoholic hepatitis. So that is the key message. So that hypothesis, the use of the plasma exchange, the earlier German study mentioned the organ failure SOFA score improvement. So this paper shows this hypothesis, not only one factor, the multiple factor, as is reducing von Willebrand factor, that could be the reason for reducing the multiple organ failure. This is our own paper in the yellow phosphorus poison, which published in the Indian Journal of Gastroenterology. Here we wish to highlight, because today the topic was the yellow. Why yellow phosphorus poison? We are giving more importance because in our state, acute liver failure or acute liver injury, if you are looking into that, more than two-thirds are the yellow phosphorus poisoning. This is we are using here King's College, but here slightly, this is, our idea, coming up. King's College criteria, actually, this is not ideal criteria in our patient to assess the acute yellow. I'm interested to look into that, Dr. Ilangumaran's talk, because what criteria he is going to use for the rat oil poison ALF, that is very important question. Because King's College criteria, most of the time, it is not fulfilling for that other yellow phosphorus poison induced ALF. So here in this study, we used the King's College criteria. Those who are not fulfilled the King's College criteria, but all of them are acute liver failure. It is not acute liver injury. Everyone has altered sensorium. That group, the plasma exchange is giving very good outcome. The other end, there is they fulfill the King's College criteria. That time, some of them underwent transplant, some of them not underwent transplant. Out of this also, if you look into that, there are 7 patients, they survived without a liver transplant. This is the usage of our studies. So why the few of them are recovering even after fulfilling the criteria? Some of them are like, we look into the parameters, which are the parameters plays a vital role to predict who will get benefit by plasma exchange. It shows post plasma exchange, if there is no improvement in INR, or this is our small study, okay, we have to do the multi-center study. If there is post liver transplant, post plasma exchange, if there is no improvement in the INR or ammonia, that group will not get benefit by a continuing plasma exchange in yellow phosphorus poisoning. So that's the thing. So that group, we have to go ahead at the earliest liver transplantation. Before to conclude my talk, this I wish to tell, not only acute liver failure in ACLF, particularly in the hepatitis B reactivation of the ALF case, that usage of the plasma exchange is giving a very good outcome. This is the recent ARC study happened with Professor Sari with multiple centers. So almost the center, various countries, everyone is experienced that if we are seeing acute exacerbation of that hepatitis B related ALF, so we have to subject the patient for the plasma exchange. It is almost avoiding the emergency liver transplant. So what is the ESL guidelines now? Is anything saying even 2017 it shows plasma exchange has shown to improvement in the transplant survival, and not only the blood, it's a level 1 and the grade of recommendation 1. So thank you for time listening.
Very warm good afternoon to all. Apollo GE department is a vibrant unit with the right experience of youth and experience, or a mix of youth, experience and youth. And with the creativity of Dr. Ubal and Dr. Seshadri, I think they'll start making movies also very soon. So thank you for inviting me to this film fiesta, sir. I have this right. So Dr. Hema, I don't think this is one indication where I will fight with Dr. Jal for liver transplantation. So I can say that there are very clear and definite indications for which we would offer liver transplant. And going on, we all understand that the mortality of acute liver failure initially was very high for all the complications like high cerebral pressures. But then with all the factors that you have mentioned earlier, the mortality is less than 50% these days. Not only transplant, the most important things are the improvement in critical care medicine, the availability of the option of plasmapheresis in these patients have played a major role in non-transplant or transplant-free survival. Definitely, liver transplant is a life-saving operation in several of these patients. And the future direction lies with bioartificial liver, which can be a bridge, and hepatocyte transplantation also. So we all have seen that acute liver injury is with jaundice and coagulopathy. And when encephalopathy starts, that is when we label it as acute liver failure. And definitely only in these patients with encephalopathy, we would offer and think of a liver transplantation. But then there are several challenges after this, right from the technical issues to the ethical issues involved in transplantation for acute liver failure, because several of these patients have been affected because of self-harm. So without a proper psychosocial evaluation, offering them the treatment such as liver transplantation, which is a lifelong commitment, may not be the right option. So is it right to offer them transplant at this point? Several questions here like that. And definitely in our country, organ shortage is a huge issue. We do not have adequate disease organ donations, and selecting the right and safe living donor is of prime concern. And also having the multidisciplinary team to manage these patients, like Professor Harris has said. So there are several diagnostic dilemmas in whom should we transplant when acute liver failure. The outcomes are, we know that it correlates very strongly with the etiology. Hepatitis A, E, a lot of these patients do not need transplant, they recover without transplant. And the indication that I mentioned here, they are the ones who are not going to improve without a transplant, but still they are at a high risk. Hepatitis B, autoimmune, drug-induced, and unidentified causes. So the etiological workup plays a very important role in prognosticating the patients very early on. And then definitely several criteria have been proposed, started from the King's College criteria, the simple MELD score, SOFA, Apache, or the Ames Red Alfred score. But one thing is for sure that apart from the tested King's College criteria, all other scores have their own disadvantages. Like the Alfred score is a very useful score to predict transplant-free survival in patients with ALF. But then if you keep waiting for 3 days, which is the criteria says the reassessment at 3 days, a lot of patients may actually be too sick for transplant. And post-transplant outcomes also, they are influenced by the waitlist mortality and the UNOS database analysis, which is published with an analysis of almost 3,000 patients showed that the only etiology with a very favorable outcome was Wilson disease, and they identified several adverse and high-risk factors. The high-risk factors were the etiologically drug-induced etiology and the autoimmune, and the adverse clinical features in predicting the outcome of liver transplant in these patients are elderly recipients, more than 50 years, patients on multiple life support, patients with poor renal function, creatinine more than 2, and very high BMI. So we all know that the patient, from the point of being identified as acute liver failure to a point of where he cannot be transplanted, that window is very narrow, and we cannot offer them transplant too early, or we cannot be too delayed, because if it is too early, the needless major surgery, there is a lifelong immunosuppression, and apart from major resource utilization and loss of a graft which could have been utilized for other needy patients. And when it is very delayed, these patients are too sick to be transplanted. So ideally, we would say that between 3 to 5 days, most of these patients are in the ideal time interval, and hence the preparation for transplant needs to be started very early on. Like I said, the ethical issues play a very major role. The underlying psychosocial issues in the recipient cannot be evaluated in all of these patients when they are in encephalopathy and intubated. So evaluating the family support becomes very important. The social support, if they will be able to support the recipient after recovery from a transplant, is definitely very important. And selection of the living donor in a highly emergent setting like this, it is a very charged atmosphere, not just for the clinicians, but from the family point of view. There can be a point of coercion on the donor. You definitely have to rule it out, and even selection of a donor with some risk factors, or if a patient has a low LAI and otherwise he's fit on all aspects, you cannot overlook it. If he needs a biopsy, you definitely need to do a biopsy, get the assessment of the liver fat, and then go, because safety of the donor is the prime. And irreversible brain, even after all the evaluation, we have seen certain patients undergo irreversible brain damage during the time of transplant. They are very well before transplant, and after transplant, they have features of irreversible brain damage. And what to do with these recipients? Do we need to withdraw the support, or we continually give them treatment? These are all the major ethical issues when transplant for liver acute failure is thought of. And with regards to liver transplantation, we know the conventional way is to remove the entire liver and give them either the whole liver in cadaver transplant or a part of lobe in living donor. But then auxiliary is definitely a viable option in some of these patients, because one, it avoids lifelong immunosuppression. And in indications like hepatitis A and B, where there is a good chance of regeneration of the affected liver, auxiliary liver transplant can be a very good indication. So this is one such picture from an article that I have taken, which shows the native liver is left behind, and a part of the native liver is removed, and transplanted left lobe, we will start the support of liver functions. And the HIDA scan, you can see that initially the graft is the one which is functioning well, and later on, after 3 months, when the native liver is regenerated and started functioning well, you can actually withdraw the immunosuppression, and gradually the graft goes in for atrophy, and the patient lives with the native liver forever. So what are the limitations of auxiliary liver transplant? It is a very challenging surgical technique, because you have to preserve the blood supply to the native liver and establish both portal vein and arterial supply to the transplant graft. And whether placing it orthotopic or heterotopic is a big question, but then there is more evidence that heterotopic, placing the liver in a different position, infrahepatic or in the iliac places, the rates of non-function of these grafts are higher. So orthotopic placement is much better. And if you have to place them in the orthotopy, you'll have to remove a portion of the liver. And this can be done safely only in patients who are hemodynamically stable and non-necrotic liver. Because with the necrotic liver, these patients manifest toxic liver syndrome. And in these patients, the priority is to go ahead and first remove the liver and even perform a shunt so that the hemodynamics improve well. The other acceptable option in very select patients is to do ABO incompatible liver transplant. Definitely, it is at a higher risk, which has to be explained very clearly to the family. The higher risk is basically because there is no desensitization possible. Even in patients in whom the titers are very low to the start, you may think ABO incompatible may be a viable option, but then the moment the graft with the different antigen goes into the recipient, they start producing a lot of antibodies and can provide hyperacute rejection and other ischemic biliary complications in the follow-up. Even early ischemic strictures, within a month, less than 3 weeks, the recipients have started developing non-anastomotic biliary strictures, and these reports are there in literature. But then definitely the outcomes have improved with better immunosuppression. One such therapy is the quadruple immunosuppression, where the induction is always added with these patients and giving them plasmapheresis in the postoperative period, doing a splenectomy, and prostaglandin infusion is also being proven to improve the outcomes in ABO incompatible. And yellow phosphorus poisoning is an endemic disease. I think ALF itself is a disease which has to be tailored. The treatment has to be tailored based on the local problem. And we've all been waiting to say which criteria. Definitely, transplantation in yellow phosphorus, which patient and when is a big question. Because the original King's College criteria, out of the entire cohort, not one patient had yellow phosphorus poisoning as an indication for transplant. So definitely, this criteria cannot be applied to identify patients who will benefit from liver transplant. The only published criteria has come from Amrita, which can be called the Kochi criteria. They are published with less than 10 patients who are transplanted for yellow phosphorus. They identified these patients based on a MELD of more than 36 and INR of more than 6. But then several validating studies after these patients who fulfill this Kochi criteria, more than 50% actually benefited without transplant. So if this question is still there, we have to identify those patients who will be benefited with transplant. And the recent LTSA, Liver Transplant Society of India, has come up with a guideline. They have more or less, there was a consensus acceptance that the Kochi criteria may be a broad outline to identify these patients. But then we all know several patients have undergone plasmapheresis already. So an INR of 6 may not be the right criteria. So if they have undergone plasmapheresis, even an INR of more than 2.5 should be accepted. And redistribution injury after liver transplant. We've talked about the yellow phosphorus being deposited in the myocardium, striated muscles, pancreas, kidneys. So will they be released into the circulation and will it affect the graft? It's still a question unanswered. There has been reports, 3 patients reported from Reliance Institute, but then it's still a question which has to be answered because definitely we need not worry for this. We need not postpone or we need not negate the option of liver transplant, thinking that redistribution may affect the graft and survival in these patients. So definitely, even in patients who have met criteria, who are prepared for transplant, delisting is a very dynamic thing. It has to be considered always. Definitely, optic nerve sheath diameter and transcranial Doppler are very important, especially in children. The acute liver failure in adults and children are a different entity. Children is mostly because of metabolic liver disease. And in these children, definitely the monitoring of optic nerve sheath and transcranial Doppler, looking at the cerebral arterial supply, goes a long way in identifying the children who will benefit from transplant. And anybody with a multi-organ failure, increasing high inotropic support, and proven sepsis definitely are not candidates for transplant. So in conclusion, liver transplantation is a life-saving treatment and have excellent long-term survival. All the problems are only in the first 2 to 3 months. In the long term, the survival is excellent. And local prognostic models need to be devised and the need is still there. An early referral to a transplant center and evaluation is always required. And listing and delisting is a very dynamic thing. Thank you.
Thank you, Dr. Elamunan and Dr. Joy Varghese. So as per Dr. Seshadri's wish, Prati sent down report on it. So, but then, so we know that acute liver failure, the 3 things, there is the critical care, the plasma exchange and the transplant is a continuum. So our aim is, if possible, yes, we have to avoid liver transplant, which we may not be able to avoid, but a good critical care and the plasma exchange is essential for an ultimate good outcome after the transplant also. So all the three components should be given at equal measure.
Just have one question for Dr. Joy. Sir, measuring one milligram factor levels, does it give any indication in prognosticating the patients?
It is not a prognostic marker so far. So, but we have, because it's a research level actually, the calculation, because it needs the HPLC, the machine to do all the assessment. So whatever the easily available biochemical mass, suppose as you pointed out, LTSI guideline says, even after the TPE, if there is no improvement in the INR, so that is the indication, might be the indication for them. Same way our study also shows there is no improvement in INR or the altered encephalopathy. So the ALF wise, how to see the response of the improvement is the whatever they mentioned, transcranial Doppler, optic nerve, because few of our patients, those who are recovered retrospectively, when we looked into their transcranial Doppler study report or the optic nerve sheath diameter and the ammonia other parameter, it showed, I mean, it is predicting, but so far there is no formula for that. Okay, beyond this, okay, patient need or less than 15. So far, there is no derivative or calculated formula.
Joy, I thought my understanding was slightly different. You know, the 1 milligram factor, de novo is not cause for all this pathology. It is only the splicing enzyme. Yeah, the splicing enzyme deficiency which causes all this pathology. So if at all it's necessary, that what is it, madam? Yeah, RMTS 13. So that measurement may be useful, not a 1 milligram factor measurement. So it's really nice. I think we should conclude. Thank you, Emma, for an excellent, very, very useful discussion. And I think we should thank every one of the panelists. They have highlighted a lot of things. Thank you, Yolanga, for a very detailed exposition for a transplant. Yes, the day will come, maybe, as she rightly said, in 2024, not definitely in 24, at least by 2020, the day will come, all these patients will be managed with probably with a therapeutic plasma exchange. And you know, the recombinant ADMT 13 has come. Maybe that is going to revolutionize, we don't know. So thank you very much, all of you, for this wonderful session. Madam Jayanti will.
Nothing more to conclude. Thank you, Hema. Thank you, panelists.
Appreciate your valuable time, and I request the panelists, the chairpersons, and the moderator to just pose for a photograph. Thank you. The next theme is going to be very, very interesting. It's going to be on the topic. It's a movie, very famous movie, Never Say Never Again. And this is going to be dealing with cirrhosis emergencies. And this character is very, very interesting because Delago is one of the villains in the movie. It's played by Australian actor Klaus Maria. He asked James Bond, which is played by Sean Connery. He asked him, do you lose as gracefully as you win? And James Bond responds, I don't know, I've never lost. That's a very, very iconic scene in the movie, and I hope it's the same with the doctors also as they discuss this theme. Thank you very much, and I welcome Dr. A.R. Venkateshwaran, former Director, Department of Medical Gastroenterology, MMC and RGGH, to chair this program. Along with him, we have Dr. M.P. Senthilkumar, Professor and Head, Department of HPV Surgery and Liver Transplantation, Sri Ramchandra Institute of Higher Education and Research, Porur. So we welcome both of you to be on the stage. The moderator for this theme will be Dr. N. Murugan. He is a Senior Consultant, Hepatology and Liver Transplant,
Apollo Hospitals, Chennai. We warmly welcome you as well. We have total of 6 panelists for this event, and it is Dr. Korselvi Rajan, Consultant Gastroenterologist, Apollo Hospitals, Chennai. We welcome you, ma'am. Dr. Dinesh Jyotimani, Director of Hepatology, Rilla Institute and Medical Center. Dr. Selvakumar Maleshwaran, Head of Liver Transplant, Anesthesia and Critical Care, Glen Eagles Global Hospitals, Chennai. Dr. Nivas Venkatachalapati, Consultant Liver Transplant and HPV Surgery, Apollo Hospitals, Chennai. Dr. Srikant Padmanabhan, Consultant in Charge, Department of Emergency Medicine, Apollo Specialty Hospital, OMR. And Dr. Ravi Kumar, Senior Consultant Interventional Radiologist, Apollo Hospitals, Chennai. A very warm welcome to all of you. Thank you.
I know Murugan for more than 31 years. Their classmates from 1979 batch. I parted in 1980. He was an MMC, I understand me. Very cool, very solid person. So very ideal person for Never Say Never Again, a famous James Bond movie. The scene, comeback scenery, as you see a comeback scene in Cirrhosis also, a comeback scenery in James Bond. The scene candy came back after beating Roger Moore with octopus. Similarly, the complication of cirrhosis is by just it's a single day team scheme. But to compress it within 35 to 40 minutes, it will be a task. I think I don't need further introduction to Murugan because I tell something about Murugan is like telling about alva to Femoral. So the complication itself will suffice. He is going to export and some of my friends, students, PGs, some of my senior consultants seen on that side. I hope this will be a very nice eye-opener to look into the complications, whether they are manageable. I don't think they are manageable fully, whether they are manageable, you can see it. Over to Murugan.
Thanks, Venkat. Always a colorful introduction from you. So we'll start straight away. I'll first discuss the case and then I'm going to ask specific questions to the panelists. The first case is a 40-year-old male. He's a small-scale businessman present with melena for one day. He's come to the emergency room. He's a little bit drowsy but arousable. His jaundice, tachycardia, BP slightly low. So on examination, he is icteric. There is mild distension of the abdomen. On palpation, liver is enlarged. He does drink heavily. His family says maybe recent abstinence about a month. Always history is very difficult in these situations, but some kind of abstinence is had. So these are the initial lab tests. I just point out the normal ones: bilirubin 32, AST 226, ALT 94, GGT 255. Albumin is slightly low, INR slightly high. Urea is 90, creat 1.1. Sodium, potassium are okay. White count is elevated. HB is around 7.8. Remember, he has melena also. Platelet around 160. So there was ultrasound done from outside in the recent past, which shows enlarged liver, some coarse echo texture, enlarged spleen, mild ascites, dilated portal vein. So this is what we have. I'll give you the diagnosis. It is acute alcoholic hepatitis with cirrhosis. There's some decompensation with a high CTP score, and MELD is also high. I think comes to around 32, 33. So it's more the discussion. This is I'll come back to this. So it's more discussion on how we can manage these patients from ER right up to ICU and beyond. So the ER physician here is Dr. Srikant. So any thoughts on how you will manage once you see these patients? I'm sure you've seen a few in your time. Anything specific in terms of liver disease, maybe?
So this is a chronic liver failure with hepatic encephalopathy and GI bleed. So as always, we would have an ABCD approach. So grade 3 encephalopathy would require some kind of airway management, if not intubation, at least nasopharyngeal airway oxygen. And he appears to be dehydrated. So maybe restoration of volume status will improve his sensorium, and we might try to avoid an intubation. He has melena but no vomiting, so that part of the aspiration fear because of vomiting should not be there. The AKI part, we need to find out whether it is AKI due to his dehydration or hyporenal syndrome. And the other thing we would suspect is, since he's got a moderate ascites, does he have a spontaneous bacterial fitness as of now? So all of this would need some initial evaluation from the emergency. So cultures, antibiotics, maybe starting on the first dose of albumin for the SBP, a referral to gastro people to consider endoscopy. His hemoglobin now is 7.8, so I would not transfuse right now, but in view of his melena, we would alert the blood bank and keep things ready in case it falls down.
Sure. So you call the gastro, so now Dr. Kochel is a gastro on call. Obviously, some hospitals, there is a gastro-hepatology combined practice. In transplant centers, sometimes it is split practice. So Dr. Kochel is called. So these are the few things I want you to address. Whether you will start any immediate medication for the upper GI bleed. What about endoscopy? Will you schedule it straight away from emergency room, wait till the patient goes to ICU, wait for some time? How long will you wait? Is there any time period before which you want to do endoscopy? And a little bit on coagulopathy correction, particularly with relation to your procedure, whether you would like to correct it, and threshold for blood transfusion. So these are some of the points I want to address.
Okay, so here's a patient, young patient, severe alcoholic hepatitis with encephalopathy and melena. And the ultrasound features are clearly showing portal hypertension also. I would first stabilize the patient, as the ER doctor mentioned, and also correct the coagulopathy based on TEG. If at all, the TEG is an easy way to correct the coagulopathy. It gives us the speed and strength of clot formation by 3 values, that is R value, K angle, and MA. Based on that, fresh frozen plasma or cryo or platelet transfusion is decided and corrected accordingly. This patient has a borderline hemoglobin and ongoing melena is there. So once he is hemodynamically stabilized, at least by 12 hours of presentation, I would take the patient for an endoscopy. And I would recommend, request my anesthetist colleague to sedate, and already patient is in grade 3 hepatic encephalopathy. So for airway protection, I would request him for intubation for airway protection and use medications for sedation like propofol or fentanyl, which has a shorter half-life and rapid clearance. And based on the endoscopy findings, therapy will be decided on bleeding esophageal varices ligation or glue injection for a gastric varix or US coiling. And threshold for blood transfusion, I would like to maintain the hemoglobin around 7 to 8 grams for this patient.
I think that's a recommendation from most guidelines now, is not to over transfuse in the early 48 hours, because over transfusion can aggravate increased portal pressure and worsen the bleed. Earlier we used to go up to 10, but now the recommendation is to keep it above 7 at least. So 7 is the threshold for most centers. Of course, if they have cardiac issues, you may want a higher threshold. Any comments from other panelists on this point?
See, the correction of coagulopathy in cirrhotics always very debatable. Most of them have very balanced coagulation profile. We only check iron, other factors. We don't check protein C, protein S, because that they also produced by the liver, I think. And doing a TEG-based correction is quite expensive. It's not available all the time. And again, in patients with varicose bleed or suspected varicose bleed, we all know that it's a pressure that causes the bleed. Yeah. So better to resuscitate the patient and then get on with the endoscopy. And
so you don't want to wait for correction before doing the endoscopy. You just do it first with respect to correction.
Sorry?
No, you don't want to first correct the coagulopathy before endoscopy. Independently, you do it. I think it's fair enough. I think even evidence shows that correcting coagulopathy has a little impact on the varicose bleed. So more important is to control the bleed locally by endoscopy. Any medication that we should use straight away?
start them on telepressin. Antibiotics, something very important because in GI bleed you get natural
I think
transmission.
two key points are telepressin and or any octreotide. What is your favor? Actually, you prefer telepressin, octreotide? Is any one better than the other?
Telepressin 1 milligram 6 hourly will be ideal to start, and if there is no cardiac contraindications, and we continue it for at least 2 to 5 days.
I think traditionally people use telepressin, octreotide, somatostatin. There's a recent paper, probably 6-7 years back, where they compared all three and found mostly equal outcomes in all three. So I think any one is used. Preferentially, most of us use telepressin, maybe a little higher dose than 4 mg, because of earlier studies showing a survival advantage compared to other drugs. But probably all three work, so telepressin, all of them. So interestingly, especially when I was a trainee, there was a study from France which showed that early telepressin improves mortality. They actually gave it at the home. When the emergency went to pick them up, they gave a shot of telepressin if they had history of liver disease. And they actually showed that outcomes are improved. So early portal hypertension measures with endotherapy is the way to approach, I think, quickly. I'll move on to the next. This is the intensive care. So now patient is shifted to intensive care. So mainly any immediate goals in a situation like this where they have alcoholic hepatitis with some bleed, encephalopathy part is not so bad, especially sedation, intubation for procedures. What is your preferred choice of sedation, or would you like to keep it without sedation, without intubation, even for a procedure? And you have written a nice review article on this elastogram, so I'd like to talk on coagulopathy management in a CLD patient who comes with different kinds of bleeding and choice of blood products accordingly. So first of all, would you like to do endoscopy in an ICU setting, or would you be happy to do it in an endoscopy?
Yeah, generally we would have more control in an ICU setting. We prefer doing it in an ICU setting, sir, but if there is a specific request from the endoscopy team about specific machinery available, we do shift on. But in general, because these patients are quite level hemodynamic otherwise, and if you want to escalate treatments, it would be way more easier in an ICU setting. So the management of ACLF patient in an ICU is quite complex, and it's actually more complex than the other patients. And generally, there are a lot of difficult decisions involved every day. So the goals would be the simpler goals would be to support the organs, which is whichever are failing, and most importantly, it would be either serious or AKI, meaning renal failures, which is a usual major components, and then anticipate, prevent, treat sepsis. Those are the two major things, and then obviously treat the cause and work bridge for transplant, work for transplant. Those things. But if you look at the organ failures, the major problem is the fluid management and hemodynamic management, which is always tricky. We need to understand the basic pathophysiology of ACLF, that there is a dynamic component of increased portal pressures, increased inflammation on top of the chronic portal pressure and the portal hypertension and the inflammation which happens in cirrhosis. So whatever we do, we need to leverage our knowledge about these things. For example, if there is a hemodynamic collapse, it's always because there is a decrease in preload because of magnetic pulling, and a decrease in afterload because of dilatation or vasodilatation. So we give a combination of afterload increasing drugs like noradrenaline, and then telepressin, which is used for the other indications, will also try to shift some of this magnetic fluid into the systemic circulation, that by effectively increasing the central volume.
So in a practical setting, you want map of
65 is the target we
even acute bleeds that is acceptable.
Yeah, and the lactate clearance and the downward lactate is always a good thing. And then unfortunately, we don't have a good volume monitor. CVP is very misleading, but the cleansing CVP generally works well. We make sure that there is nothing obviously wrong in the heart too. So sometimes
any thoughts on sedation, Selva?
Sedation, yes. Sedation, we prefer short acting in case we go for intubation, not for a non-intubated patient. So short acting can be propofol, or sometimes it can be dexamethasone. It's more about what not to give, which are benzodiazepines and long-acting opioids, than what to give. And the coagulopathy, again, we don't really chase up the INR because we feel INR is more a marker of renal failure than a coagulation status. So the coagulation status, as like Dinesh was saying, is we have a rebalanced hemostasis and there is a fall in procoagulants and the anticoagulants. So generally, it may be in a balance. There is a decrease in platelet count. There is also increase in 1 milligram factor. So the primary hemostasis also is balanced, and there is a decrease in plasminogen and an increase in plasminogen nitrator. So generally, it is in a rebalanced hemostasis, which can tilt either towards thrombosis or towards for bleeding. So viscoelastic measures obviously are good, and viscoelastic measure based correction also we try to avoid volume. If at all we need to correct, we go with concentrates, factor concentrates rather than lot of FFPs. Cryos are okay. If you pick up a lysis in a viscoelastic monitoring, giving tranexamic acid is a safer option because prophylactic tranexamic acid has not been found to be used in OGTs. So if there is a demonstrated fibrinolysis, tranexamic acid will help. Cryoprecipitate is reasonably safe, but giving a lot of FOPs we definitely avoid.
It seems to be less important in variceal bleed to focus on correcting coagulopathy. Like Dinesh mentioned, I think the focus is to stop the bleeding endoscopically. But if there is ongoing bleed of other kind in an ACLF patient, then this approach may be useful. So would you go nowadays by tech-based correction or you go by individual INR platelet individual correction?
No, we don't chase up INR. We never chase up INR. Even for surgery, we recently had with INR 3.5, we had uveal abscess and complete debridement. We didn't transfer anything because it was normal. Of course, it can tilt into either side. At any point of time, we have to have a close watch. And waiting for a coagulation correction for endoscopy is double-edged sword because there is ongoing bleed and the transfusion of PRPs is going to dilute your factor concentrate factors in the blood a little bit more. So the earlier there is a mechanical correction, the better.
I agree. So there are some studies comparing tech with conventional approach to individual components. It's a review article from World Journal of Gastro. 4 studies showed that overall blood product use with tech-guided correction may be less. We actually save on blood products. And in those with variceal bleed, maybe the rebleeding rate was lower in the tech-guided transfusion group, which was statistically significant. But one of the main advantages of using tech seems to be that the hemostasis assessment may reduce the transfusion requirement and related adverse events. But overall mortality, length of stay didn't seem to change too much.
This is the same situation in the liver transplant setting also. Egg and rotem are found to decrease the FFP transfusions, but has not been shown to be improving the outcomes or improving even the blood loss or decreasing the blood loss. I think it is all too multidimensional for one intervention to have change in outcomes, but generally it reduces unnecessary transfusion.
So it's a question for Dinesh. So we think this patient has alcoholic hepatitis. I had a slide early on which helps you to diagnose alcoholic hepatitis in clinical terms rather than doing a biopsy. So I'll just go through that. This is the consensus statement from the NIA in the US. Because alcoholic hepatitis is a histological diagnosis, but it's not always possible to do histology in these sick patients. So they came up with a working definition, partly for clinical management, partly for studies, that you have onset of jaundice, which is defined as bilirubin more than 3 within a 60-day period of heavy drinking, with elevated AST, ALT ratio more than 1.5, and no other identifiable cause for hepatitis. You can call it as an alcoholic hepatitis, and they divide it as definite, probable, and possible with an error rate of 10 to 25%. And with this, they were able to identify patients on a clinical basis. So assuming this patient has a strong suspicion of alcoholic hepatitis, you corrected the GI bleed, you're managing the complications. What do we do next? I mean, one option is a transplant, but if the chronic component is less, it is more of an acute component. Can you save these patients from a transplant? Can they live 5 years without transplant? Are there any drugs, any approach that you use? And if you're going to use drugs like steroid, would you want a biopsy before using them, or you're happy to use it in clinical setup?
Sure, we can do that step by step. So first of all, we need to know whether this is alpha hepatitis per se, where they may not have ascites, or this falls into acute and chronic liver failure. The prognosis may be slightly different. And this gentleman came with a bleed. Obviously, that's got sorted out, and we have to ensure that he is not septic, and this should be adequately covered with antibiotics. The other gentleman said spontaneous bacterial peritonitis can trigger, viral bleed. So if we ruled out all those things, most of the time the bilirubin may start settling down on its own. Okay, that's what we've seen in our experience. In terms of how do we manage these patients further, personally, I'm not a big fan of steroids in alcoholic hepatitis, because if you look at that gold standard study, there's only 3% difference between those who got better with steroids and those who did not get better with steroids in the placebo arm. And also at this point of time, if you're going to use steroids, you're going to unnecessarily risk this patient for sepsis, septic complications, and bacterial as well as fungal. And what I would prefer to do is to feed them. Most of these patients are quite malnourished, and feed them early and see how the liver disease progresses over a period of time. And most of the time, it may just settle down. Other therapies, again, plasma exchange, it's a double-edged sword here. It's simple, keep things simple. Vitamins, antibiotics, control the bleed, control sepsis, high protein diet, nutrition management. I think those basic management plays a major role in these sort of patients.
This patient, the scenario that I described, will fit the criteria for ACLS. So this is a combination of alcoholic hepatitis with ACLS. So this is the ECL definition and APASL definition of ACLS, where they have described the acute deterioration of a pre-existing chronic liver disease related to a precipitating event. In this case, it may be alcohol or GI bleed or some infection. And there is a mortality within 3 months. APASL has included that either ascites or HE within a 4-week period with a high 28-day mortality. So this is the ACLS definition. And there are 2 scoring systems to grade ACLS. One is the Crrp score, which uses many variables, including liver and other organs. And other is the AARC scoring system, which is by the APASL group, mainly led by Dr. Sareen and ILBS, where they used, again, mostly liver-based and lactate and creatinine as the parameters. And based on the scoring system, you can get a grade of the severity of the ACLS. And the prognosis will worsen depending on the grade. And there are some recommendations for transplant based on the grade as well. For example, in the ARC score, if the grade is more than 11, then liver transplant may be indicated. So either Selva or Dinesh can answer. When you have a high grade ACLS, should we go for transplant? How long should we wait? 3 days, 7 days, whatever time period? Should we try advanced liver supports like FLEX or other types of ALS? Is any your experience and any literature that you know of that will?
I mean, first of all, we need to see how the patient progresses over the next 48 hours.
So the bleed is stopped, but his ACLF is worsening. He's drowsy, he got intubated.
Yeah, so he is probably ACLF grade 2, or even more than that. Actually. But again, just going on and transplanting them immediately may not be the ideal therapy, because again, a lot of logistics involved with that, and organ availability. You have to justify transplantation when you transplant such patients. You don't know the natural history of the disease. So better to wait for a few days, take him out of the sepsis and see how things go. And that's what in real life we do, actually, rather than offering them transplantation immediately.
I think ACLS is a difficult area because there is no consensus and the presentation is so variable. You can't box them as one group. So it's the hardest area for all of us treating liver patients, how to manage and when to transplant and when not to transplant. So many of the guidelines recommend 3 days and 7 days. And the end of 7 days, if there's a declining trend, they may get better. If not, you may consider transplant if they meet the criteria. So any comments on that, about?
Yes. So,
and also comment on something like plasma exchange, should we do or not?
Yeah, so regarding the scoring system, that most important point as you emphasize this, it's not the score on presentation which is important, it's the score on 40 hours which is important, because the initial resuscitation might change things. And the 40 hour score is associated with 28-day mortality, even up to 1 year mortality. So when the patient is in grade 2, 3, ACL grade 2, 3, grade 2 or 3 or 40 hours, it is, I think, better we have an accelerated post-post transplant, because we may not have that window available forever. And the scores, it's a tracking of the organ failures by committee. So at some point, if the organ failures are becoming more, and especially if it incurs the respiratory failure or the Crrp score is more than 64, then comes the question of fertility also. So it is a very narrow window there, and we are thinking about it. Regarding the bridge therapy, again, plasma change in a multi-organ failure patient is very tricky. Out of all the organ supports or extracorporeal liver supports, Mars is more like a surgical strike, and plasma change is like a carpet bombing. So it removes everything. It might improve the good things, it might improve the bad things, the growth factors. So when the patient is having a bottling sepsis and the patient is really going for transplant, we try to avoid. If there is a polyester liver failure based situation where we don't have cardiorespiratory failure, we do try to.
Okay. So any comment from the audience or chairperson before I move on? You want to know flex itself can cause sepsis? Probably less likely. No, whether flex itself can cause sepsis, just doing flex.
Generally, theoretically should not, but what happens is the globulin levels change drastically. So the immunoglobulin levels drastically. And the fact that there is an extracorporeal circulation and there is a handling of the central venous access and all, theoretically, the Crrp rates are definitely up. The central venous infections are up. And the immunoglobulin levels go down rapidly. And we have seen that they develop more candidal infections. People who have had repeated plasminogen outside the common, we try to start with technocandidal start with, because we have too many candidal infections in this, so might be increasing the sepsis.
One I want to add is the etiology of acute precipitating factor plays a major role as well. Say, for example, most studies from the Western world, it's based on alcohol, acute alcohol hepatitis, the French study, and studies from the East is acute hepatitis B reactivation. So they have a different outcomes actually. That too, acute alcoholic hepatitis in a selected patients, it's shown to improve survival. But again, we have to choose the right patient, and it's not very clearly established who, as you said, like alcohol liver disease is a very difficult situation to manage. And most of the patients can be septic, and they're quite sarcopenic many times. So we need to know the acute precipitating factor. Say, for example, this gentleman came in bleeding 32 1 month after abstinence. So whether he has taken any native drugs in between, that's something we need to take a detailed history of.
Lilly's criteria, steroids is basics. If there is no steroids, Lilly's criteria, acute marker is totally applicable.
Yeah, I think if you're using steroid, you should use it based on response score, on Lilly score. So you give steroids for 7 days and then repeat the score. And if the score shows that there's a response, then you can carry on giving the drug up to 28 days. Reason being that there is an increased incidence of sepsis, especially in the 3rd and 4th week. So if you continue steroids, you have to justify that it is working. So the Lilly score is a useful guide. But in this situation, our concern is not to use steroids because of ACLM, but in another setting, maybe it works. Sure. That's Ravi Kumar's role. So I agree. I think in ACLF with alcoholic hepatitis, generally we avoid steroids. But in countries like US and Europe, they are forced to use steroids because that's the only way they will get a liver. They have to show that they have failed steroids. Steroid ineligibility, as of now, they are not able to get a liver in a DDMT setup. It's probably not relevant for India. And my own practice is somebody comes as outpatient without much failure, the cirrhosis is early, but the hepatitis component may be high. they may benefit from steroids, especially if they don't have ascites, bilirubin is high, INR is high. They benefit from steroids. So very often we ask our colleagues to do a TGLP or a conventional biopsy to diagnose acute alcoholic hepatitis before putting them on steroids. So your experience and thoughts on TGLP in a sick liver patient, and what precautions you will take briefly.
Yeah, this patient has INR of 2.7, but platelet count remains 160. So TGLP will be the best choice in this patient. And because though we say TGLP,
so when will you consider TGLP versus a conventional?
When the bleeding parameters with INR is greater than 1.5 and if the platelet count is less than 50, so up to 50 at least, then we would rather prefer doing TGLP. And if the MELD score is more than 24, they found that the hemorrhagic complication is quite high. So though we still say TGLP has got the least risk, but doesn't avoid bleeding complication per se. So in spite of the TGLP, like there's another technique which has been devised saying it's a transfemoral transcable biopsy. The basic difference is in a TGLP, we direct the needle towards the porta, that is towards the hepatic artery, portal vein, and the biliary system, which is central. But in a transfemoral transcable, which is away from the thing, so the risk of bleeding has been found to be very less. Though I personally have done only a couple of cases, but literature says it's good when compared to TGLP. We can do trans.
TGLP, do you anticipate any bleeding or it is taken care of?
Now, what we have done is before we were using only fluoroscopic guidance. Now we started using ultrasound and fluoroscopy. A very shrunken liver, there's still a chance because we can still, the needle can penetrate the subcapsule, the precapsular area, and that can cause bleeding per se. So with the ultrasound guided and fluoro guided, these complications can be avoided to a great extent.
Okay. And you correct coagulopathy before procedures, or you leave it to the liver?
Generally is advised so that we don't want to correct, but if it's more than 1.7 and at least more than 2, I would say definitely have some correction at least to be on the safe side.
So this is the problem. We still don't have consensus how to manage coagulopathy in terms of procedures and in bleeding. Whether you correct them or not, because you know that INR may not reflect the bleeding potential, but even legally, I don't know whether we are obligated to correct or not if they have a bleed. So you would prefer some correction?
Some correction, at least during the procedure, some FFP transfusion and then all that.
And just move on to water time.
It's an interesting situation because there's a young man who has come with bleed in the setting of alcoholic hepatitis, ACLF transplantation. But he does not have any overt sepsis, no other organ failure, apart from coagulopathy and liver failure. So he'll come to ACLF2. And I think we've done the first thing right, the bleeding part has been controlled. And the next step is to, he's a very high melder. Meld is 30 plus. 30 plus. Now build of 3. And very unlikely he'll respond to any medical management and in the medium term. And you can't give him steroids. So I would feel that if really involve the transplant team quite early in this patient, it's quite likely he'll almost certainly need transplant. And going by various prognostic criteria, he's not going to survive without transplant. Short-term mortality is very high. He might end up controlling the bleeding and bring his blood slightly down. Maybe some of his other parameters might come down. But if you just keep delaying, he'll just go into sepsis. And one after another, you'll have organ failure. And this is the first week. I think we have time to stabilize him reasonably from bleeding point of view for the first week. And after that, you should really think about transplant quite soon. Transplant. That's what I would do. And I don't know how beneficial liver biopsy is going to be in this particular patient. Liver biopsy.
I think in this particular patient, probably not, because they're not, probably we won't use steroids or aggressive treatment to reverse them, but in a more like outpatient or less sicker patients in the ward, sometimes we do.
If there's a doubt whether we may or may not need transplant, that's fine. You can use biopsy as a prognosticating. approved, but not in this way. It clearly needs transplant.
Because in countries like US, they have a criteria that they should have paid steroids to put them on the list. So probably ACLS, they may not do biopsy, they may just put the MEL score and try to get a liver. But otherwise, they have a problem in getting liver. So sometimes they do a biopsy just to document. Dr. Nivas can take up on what Dr. Sendil said. He feels this patient more likely will end up in transplant. So, assuming, okay, we are referring to for transplant. So, what are the ethical considerations because he's not been abstinent for sufficient period of time? Rate of success of the surgery and the recidivism rate, any thoughts on that? And liver transplant and ACLF, obviously the success rate will be different from a straightforward CLD patient who is not very sick, who comes from home. So what is the success rate that you think is you're likely to get? And final, most important question for any surgeon is when not to transplant. When you decide, no, I won't take this patient.
Alcoholic hepatitis. The question is yearly transplant for alcoholic hepatitis. So that in 2011, the landmark trial from Philippe Martin from French Belgium group that showed that the patient benefited better with the yearly transplant, and the both the yearly transplant group had a better advantage, and the other is the recidivism, that is only 14% of the patient had a recidivism. After that, a lot of centers in Europe started doing yearly transplant. In US also, they have started doing later in around 2018, and they found that a study from Lee has shown that the yearly transplant is giving a better results, and the recidivism is also less. These are both Europe and USA based on a dead donor donation. For a country Asian population, mainly a dependent on living donor donation. So if the family is willing to support the patient, and the patient is also properly motivated, and if he is ready to accept that he is having a drinking problem, and if psychiatric issues are ruled out, and if the patient is fit to undergo transplant, I think we can go ahead with that.
It's a very difficult challenge, Nivas, because acute patient who's sick, who can't answer questions, family very emotional, very hard to know whether he will drink again or not.
Yes.
So, but we are faced with this reality all the time. It's very hard to tell the family, no, I won't transplant them. Even if you have a donor, I will not because he's drinking. It's very hard to tell. So it is a problem for all of us. We just have to do what we can. Interestingly, there was a paper from Medanta where they done early transplant in an Indian setup, almost 60 patients, and they found the relapse rate was very low. And they said that in Indian culture, with family around, they usually prevent mostly males from drinking again, which is slightly different from the West, where they are mostly alone in their life. So the criteria that the West uses may not apply to India, and if you feel somebody is fit enough, we should transplant. That's what their paper concluded. So it's a difficult problem for us in terms of ethics. So in terms of success rate, are you happy to transplant ACLF?
ACLF patient, the success rate is around 5 to 10% less than the CLD patients, which we are where the patient is stable. These patients are along with.
I'm talking about 1 year survival.
Yes, 80 to 80%, 1 year survival.
Okay.
So when there is no other option when the patient is going sick like 2 organ failure and greater than that, like 3 organs, then liver transplant will definitely benefit these patients.
And when, as a surgeon, will you say, I don't want to transplant these too sick?
If there is some multi-organ failure along with that ongoing sepsis, and if the patient is on ventilator and the oxygen requirement is increasing, and CRP, where in spite of that the kidney is not improving, now signs of improvement, in all those conditions, it's better to the transplant will be protected in those.
Any thoughts on that, Dinesh and Selva, when not to transplant?
Even in ACLF3, timing of transplantation is very important, and you should have a better survival than without transplantation. Of course, they should be free of sepsis,